Welcome. This session will be on how to assess a patient with an orbital problem. So it starts with the history and we inquire about symptoms such as pain, altered sensation, diplopia, globe displacement and decline of vision. Apart from infection, inflammation and orbital hemorrhage, it is important to remember that patient will have pain in situations such as lacrimal gland malignancies, invasive nasopharyngeal carcinoma and metastatic neoplasias. We also inquire about the onset and duration of the symptoms, and the duration is for days to few weeks in cases of infection and inflammation, as well as in fulminant malignancies such as rhabdomyosarcoma and neuroblastoma. The duration is for weeks to a few months in malignant tumors and from months to years in benign tumors. We also inquire about significant previous medical history such as thyroid disorders, systemic inflammatory disorders, sinus disorders and malignancies which can present with orbital signs and symptoms. Inquiring about a history of trauma to the head or face and about family history can turn out to be important in relevant situations. Examination of a patient with an orbital presentation starts with a complete routine ophthalmic examination just like any other patient, with a particular attention to globe displacement, ocular motility and signs of optic nerve compression, because lesions in the orbit tend to cause abnormalities in these three signs. So proptosis is a forward displacement or protrusion of the globe, and it can be axial if it is directly forwards, and it is non-axial if it is forwards as well as displaced to one side. Axial or purely forward proptosis is caused by intraconal space occupying lesion, that is lesions lying within the cone of the recti muscles such as cavernous hemangioma, glioma and meningioma. Non-axial proptosis is caused by extraconal space occupying lesion, with superior displacement being caused by lesions such as invading maxillary sinus tumors, inferomedial displacement being caused by orbital dermoid cysts and lacrimal gland tumors, that is lesions which are situated superolaterally, and inferolateral displacement caused by lesions situated superomedially, among which we also have orbital dermoid cysts, frontoethmoidal mucoceles and ethmoid sinus carcinoma. Exophthalmometry is the technique of measurement of the anteroposterior position of the eye. The Hertel exophthalmometer, as shown in this picture, measures the anteroposterior distance from the lateral orbital rim to the anterior cornea, and the Nagel exophthalmometer measures anteroposterior distance from the superior or the inferior orbital rim to anterior cornea, and this exophthalmometer is used when lateral orbital rim is either displaced or absent following surgery or trauma, and Nagel exophthalmometer can also measure vertical displacement of the globe. Normal values of exophthalmometry is 16 to 18 mm, with males having a larger value than females. A difference of 2 mm or more between the two eyes is abnormal and is appreciated best by the worm's eye view, in which we ask the patient to tilt up the head and examine from the level of the chin. And in this situation we see that the left eye is protruded forward as compared to the right eye. Proptosis can be bilateral, and thyroid eye disorder is the most common cause of bilateral proptosis. Thyroid eye disorder is actually the most common cause of both unilateral and bilateral proptosis in adults, and this is very important to remember. Non-specific orbital inflammation can also involve both the orbits, causing bilateral proptosis, and other causes of bilateral proptosis include lymphoma, leukemia, metastatic tumors, metastatic neuroblastoma in children, and vascular disorders such as cavernous sinus thrombosis and carotid cavernous fistula. Pseudoproptosis is an abnormal prominence of the eye, which is actually either a simulation or a true asymmetry without an increase in the volume of orbital contents. So in pseudoproptosis we have prominence of the eye without an increase in the volume of orbital contents, and pseudoproptosis is always a diagnosis of exclusion when we have ruled out an orbital lesion. Causes of pseudoproptosis can be globe asymmetry, as in megalocornea or contralateral microphthalmos, lid asymmetry, as in lid retraction and contralateral ptosis, orbital asymmetry, or contralateral enophthalmos. Other descriptive terms used to describe orbital disorders include telecanthus, in which there is an increased distance between the medial canthi. So this is a patient of telecanthus. In hypertelorism or teleorbitism, there is increased distance between the medial orbital wall, as seen in this picture. In telecanthus, as the distance between the two medial orbital walls is not increased, the interpupillary distance is normal between the two eyes, although the distance between the two medial canthi is increased. But in hypertelorism, the interpupillary distance between the two eyes is increased. Exorbitism is defined as the situation in which the angle between the lateral walls is more than 90 degrees. And enophthalmos is retraction of the globe. And enophthalmos can result from orbital fracture, silent sinus syndrome, and sclerosing tumors such as metastatic breast carcinoma. We also have to look for periorbital changes in patients with a suspected orbital disorder, which includes lid retraction and vascular congestion over muscle insertions in thyroid eye disease. So lid retraction is shown in this picture. Salmon colored masses in conjunctival cul-de-sac, as found in lymphoproliferative disorders. Periorbital ecchymosis, which is found in situations such as metastatic neuroblastoma, leukemia, and amyloidosis. S-shaped eyelid deformity, found in plexiform neurofibroma and lacrimal gland tumors, and corkscrew conjunctival vessels, as shown here in vascular abnormalities such as carotid cavernous fistulas. Ocular movements and lid abnormalities must also be checked in patients with orbital disorders, and it is important to remember that in thyroid eye disease, inferior rectus is most commonly involved, resulting in restriction in upgaze and hypotropia in primary position. Also, lid lag or von Graff's sign and lid retraction are the most common physical signs of thyroid eye disease, and these are very important signs in thyroid eye disease which needs to be remembered. After inspection, we palpate around the globe for any mass lesion, and mass lesions in the superinasal quadrant can be dermoid, mucocele, encephalocele, or rhabdomyosarcoma. Mass lesions in the superotemporal quadrant can also be a dermoid or a tumor or prolapse of the lacrimal gland. We can also check for resistance to retropulsion by pushing both the eyes simultaneously posteriorly towards their respective orbital apices, and an increased resistance to this retropulsion can be due to tumor or inflammation. So it is not only tumor that cause an increased resistance to retropulsion, but inflammatory lesions can also increase the resistance to retropulsion. Palpation can also reveal pulsation, and pulsations can also be auscultated. Pulsation can be due to abnormal blood flow, as found in situations such as carotid cavernous fistulas, or due to bony defects transmitting intracranial pulsation, as found in meningoencephalocele, mucoceles, neurofibromatosis associated with sphenoid dysplasia, and loss of bone following trauma or surgery. Imaging is very important in orbital disorders, and most if not all orbital presentations require imaging, and options for imaging include CT scan, MRI, and ultrasound. CT scan is based on X-ray, and it is the most important imaging method for orbit. It is the modality of choice for bony lesions and orbital fractures, but soft tissue details provided by CT scan is also enough for almost all orbital pathologies. So CT scan is sufficient as an imaging technique for almost all orbital situations. CT scan is able to characterize location, extent, shape, and nature of most orbital pathologies, because radiolucent orbital fat provides adequate contrast. It may also help to guide surgical approach by showing relation of a lesion to surgical spaces in the orbit. CT scan can also be done with a contrast agent. in which case it is called CECT, and it is helpful in lesions with abnormal vascularity or altered vascular permeability. For orbital CT, typically 3 mm cuts are taken compared to the routine 5 mm cuts for head, and fine cuts or 1 mm cuts can also be ordered for more detailed information. After the data is accumulated by the CT scan, the image can be reconstructed either two-dimensionally or three-dimensionally. The two-dimensional reconstruction can be either axial, parallel to the optic nerve as shown in this picture, or coronal, that is perpendicular to the optic nerve as shown in this picture. And coronal CT scan is helpful in lesions of optic nerve and extraocular muscles and for floor and roof of the orbit. Sagittal reconstruction of CT scan parallel to the nasal septum is rarely done. Three-dimensional CT scan is not done routinely and is only reserved for complex orbital fracture repairs and for craniofacial anomalies. The other important imaging modality is magnetic resonance imaging, and importantly, it does not employ ionizing radiation. The principle of MRI has been described in the section on neuroophthalmology. Now, if we compare CT scan with MRI, advantages of CT include good visualization of bony lesions and calcification, which are poorly imaged by MRI. And CT scan is safe in patients with metallic foreign bodies and implants, which are contraindications for magnetic resonance imaging. CT scan is quick, less expensive and less claustrophobic as compared to MRI, and since it is quick, it causes less motion artifacts. Advantages of MRI as compared to CT scan include better view of soft tissues at the orbital apex, where because of crowding of tissues, resolution of CT scan may not be adequate. And being devoid of ionizing radiation, it is safe in pregnant patients and in young children. And contrast MRI examination with gadolinium salts can be done in patients with iodine allergy in whom iodinated contrast agents cannot be injected for contrast enhanced CT scan. Angiography is indicated in selected situations to detect arteriovenous malformations, arteriovenous fistulas and aneurysms, and angiography can be done with CT or MR without injecting a contrast agent, or a catheter angiography can be done in which contrast agents need to be injected but is still considered gold standard in angiography. Ultrasonography has limited value in orbital diseases but may help in evaluating echogenic character of tumors, detection of foreign bodies in the orbit, or evaluating vascular lesions with Doppler technique. So in this situation we can see fluid accumulation in the orbit following inflammation. For pathological studies of material removed from the orbit, crush and cauterization injury should be minimized, and for routine histopathological examination, the tissue is immersed in formalin before being sent to the laboratory. For frozen section biopsy at the time of surgery, and for cell marker studies with flow cytometry in cases of lymphoproliferative lesions and metastasis, the tissue should be immersed in saline and not in formalin, and glutaraldehyde should be used for tissues being sent for electron microscopy. Fine needle aspiration cytology can be done under ultrasound or CT guidance, and genomic studies on tissues can also be done. Situations where laboratory workup is required for patients with orbital diseases include thyroid eye disease, in which serum T4 and TSH are routinely evaluated and turn out to be positive in more than 90% of patients with TED. In TED suspects with a normal T4 and TSH, thyroid stimulating immunoglobulins, also called TSI or TSH receptor autoantibodies, are analyzed. In granulomatosis with polyangiitis, previously known as Wegener's granulomatosis, cytoplasmic pattern of staining of anti-neutrophilic cytoplasmic antibody is assessed, and in sarcoidosis, serum angiotensin converting enzyme and lysozyme are evaluated. Thank you for listening.